is the changing of the bilirubin into an excretable form. Conjugation, not unconjugation. Conjugation is the changing of the bilirubin into an excretable form. So it's the conversion of yellow lipid-soluble pigment, unconjugated, into a water-soluble pigment, excretably direct. Okay? So the unconjugated is non-excretable. It needs to be changed into a conjugated so it can be excreted. Okay? Did that clear it up a little bit?
So unconjugated, in the book, if I'm correct, it's unconjugated then, crosses the placenta to be excreted. The fetus does not need to conjugate.
Oh, okay, but we're talking after days. Now that the baby is a newborn, they have to take over. Yeah. Okay. So once it's conjugated, it can be excreted. Is that clear enough? Okay.
So the conjugated changes the bilirubin from a yellow lipid-soluble pigment into a water-soluble pigment.
Correct.
Okay.
Okay?
Thank you.
You're welcome. All right. Now, okay, gastrointestinal. So, one of the findings you may see when you're assessing the baby is Epstein pearls. Did anybody get to see those? They're kind of hard to see because you have to look at the roof of the baby's mouth. And they look like little pimples. Actually, they're little yellowish, whitish, raised bumps. And that's just a normal finding that you may see with the babies. The cheeks are full with sucking pads to help them eat. They're born with the ability to swallow, digest, metabolize, and absorb simple carbs and fats, emulsified fats. So they're born with the ability to swallow, digest, metabolize, and absorb simple carbs and fats, emulsified fats. Sometimes the Epstein pearls can actually be found on the gum line too, but typically they're on the roof of the mouth. What we need to remember is that babies born before 32 weeks, their sucking is not developed. So that's a problem with our preemies, right? So sucking in the newborn is coordinated with breathing and swallowing, and it occurs in small bursts of 3 to 4 sucks at a time. And again, bacteria is not present in the infant's GI tract until they start eating. So once they start eating, this is kind of gross, right? It is soon present in their GI tract, which helps them synthesize vitamin K, make vitamin K. So within the first week, they end up being able to handle any bleeding issues on their own. Meconium, anybody get to see meconium? That dark, sticky, gooey first bowel movement is a combination of amniotic fluid, intestinal secretions, cells, and usually pass within the first 24 hours. If they don't have a bowel movement in the first 24 hours, we start to get a little concerned. So the first meconium is actually sterile, and then stools after that have the bacteria. frequency of stools vary, but we just want to make sure before our babies go home that they at least have that one stool past that meconium. After that, you'll see a transition. They become green. They're different for breastfeeding moms, more yellowish, seedy, but these are some different colors. So you have the meconium, we call it transition stool, which is kind of brownish green, and then they get into yellow. As long as the stool is soft, the newborn is not constipated. Looking at their renal system, they don't have the ability to concentrate urine yet. So if we did a specific gravity, which we don't typically, it would be 1.001 to 1.020. They are not able to concentrate their urine until about 3 months. But the urine should be straw colored, odorless. If there's any cloudiness to it, it may be due from the mucus that they secrete, which is normal vaginal mucus that you'll see sometimes with our females especially. Also, did anybody get to see pseudo-menstruation? We call that pseudo-menstruation when little baby girls have a little blood in their urine or vaginal. Actually, it's from their vagina. Vaginal discharge has a little bit of blood in it. So we need to tell our moms that this is normal, not to worry. It's because of mom's hormones that they may see this. So what we should see is voiding. Also, we want to make sure they have their first void within 24 hours. And they should have 2 to 6 voids during the first 24 hours. Then it can be 5 to 25 times during the subsequent 24 hours. I'm not sure that chapter is right. But assessment of our newborn. So definitely okay, assessment. Of course, we're doing an assessment immediately after birth, determining whether the baby needs any resuscitation, determining gestational age and adaptation to birth. Then, within 1 to 4 hours after birth, there'll be a complete physical exam, checking nutritional status. And then the pediatricians come in every 24 hours and do their own assessment on the baby. So, just know, don't worry about all of the different findings that you may see on the assessment of the newborn. Just zero in on the ones that I've talked about in class. characteristics. So just look over those. Page number. What is the page? 571. 571. With the new book? Oh, no, that is what I had as notes. Okay, well, anyway. Sorry, guys. Okay. There's a page with all characteristics. Just concentrate on the ones that I discussed. 489. 489. Thank you.
Are you talking about the big chart?
Big chart.
That's on 513.
Thank you. We'll get there. Okay, 5, yes, that's what I'm looking for. 513. Know everything for the assessment. You guys know that. Because of the assessment you've done in the clinical setting and that I've demonstrated. There's a list of, like Epstein pearls, Golian spots, all kinds of. Okay, anyway, moving on. Yeah, as I said, just review your physical assessment and the things we wanted you to know on the physical assessment checkoff. Know that. Okay. All right. Stoichiometry and test. You put on this a lot. Acrocyanosis, definitely know what that is. It can appear intermittently over the first 7 to 10 days, but it is not an abnormal finding. Know the difference between caput succedanum and cephalohematoma. So caput, I remind you that it's just like a cap sitting on top of the head, and there's edema in the scalp, mostly on the occipital point. Occiput. Cephalohematoma is off to the side, can be on both sides, and that is a collection of blood, and both of these are okay. They're just from delivery, and we will watch them, but they will disappear on their own. It's the blood between the skull, bone, and the periosteum. So really looking at the scalp, the cephalohematoma does not look blood-filled, so you can't really tell the difference. The only way you can tell the difference is the caput crosses the suture line and the cephalohematoma does not. So the caput succedanum, it disappears by about 3 to 4 days. And the cephalohematoma takes a little bit longer, about 3 to 6 weeks. When a baby has a cephalohematoma, they are at risk of having a bigger problem with jaundice because they've got all these blood cells also to break down. So we keep that in mind that they may have a higher bilirubin that's left, breaking down of those extra blood cells. And what shape is the anterior fontanelle? Diamond shape, okay? And it closes at 18 months. Okay, so remember that. Anterior fontanelle, diamond shape, closes within 18 months. And the posterior fontanelle, which is really hard to feel, it's much lower, closes within 3 months. And what shape is it? Triangle. looking at the skin. With our babies, we might see desquamation or peeling of the skin, and this occurs a few days after birth. And moms want to put lotion on these babies, but they really don't encourage that. They discourage it. Vernix is really a good hand motion if you follow this. We talked a little bit about that, but that is due to the sebaceous glands. And if you remove it too vigorously, that'll make the dry skin worse. So it's better to just lightly wipe it off and let it absorb or disappear on its own. Milia, so these are some things that I want you to remember. Those are the little white places on the nose that a lot of times you'll see on babies. And it's just distension of the sebaceous glands, and it's on the face. We just want to tell our moms not to pick at those if we notice them. They're not pimples and they will go away on their own. But that's a normal finding. Mongolian spots are a normal finding in our Hispanic, African American, darker complexion cultures. And it looks like a bruise typically over the coccyx area and the bottom area, and some of you have pointed those out to you in clinical. And that's a normal finding. And it needs to be documented because it actually looks like a bruise, so a mother could be accused of losing her child, and it just be a Mongolian spot. So you want to make sure you document all those. You may see some different levis, and that's common also. And then you may see erythema toxicum. And this is newborn rash. That's a big word for newborn rash. And it will disappear without any intervention. But again, it looks like little spots, random spots on the baby. That's a birthmark. So you might see different birthmarks. Yeah. This is a great picture of a baby with molding. Because the baby has to mold its head to get down to the birth canal. So you see how elongated it is. Some of them have it worse than others, and again, we want to tell our moms it's normal, it's no molding, to get down to the birth canal, and baby's head will go back to normal. Looking at the neuromuscular system. So babies all have spontaneous motor activity. And, you know, they have the startle reflex or the mora, and it can be misinterpreted for tremors. Now, do you know what tremors would indicate? Seizure, okay, it could. Could be withdrawal. Okay. But in a non-situation like that, do you know what it would be? Okay, a lot of times blood sugar can be an issue, right, with our babies. So if we see a baby that's really tremoring a lot, that would be something that we want to rule out. So we would want to check blood sugar on them. But you're right, those other things can be the case too. Their neurovascular system is almost completely developed. You know, we go through all those reflexes, the Gallant reflex where they cock up that hip when you put your nail up the side of each part of the back. So, but if we do see the tremors in the mouth and the chin, they just need to be distinguished from convulsions, exactly, and withdrawal and hypoglycemia. So that some of the reflexes that you might be able to see, the tonic neck is kind of hard to see in our newborns to elicit it. We see this in our babies that are on the radiant warmer just laying there. typically. And do you remember what that is? So when they turn their head, that arm is straight and this leg is straight like we're going to net. So we're also the fencing position. And this side of the body will be flexed. And you'll just notice that. It's really cool if you can catch it in the nursery if you're on the reformer. But, you know, typically we have them swaddled up and, you know, just the quick assessment that we do, we can't really elicit it. Supposedly you can if you turn their head to the side. I haven't had a lot of luck with that. Tomorrow we talked about, it's a startle. And they do the C with their hands. And these are all telling us that their neurovascular system is intact. Sucking and rooting, you know what sucking is. Rooting, where you rub the teeth, because supposedly they'll go that way, and that helps them with breastfeeding. Grasp are fun, too. They got funky hands and feet. So if you put your finger in their hand, they'll grasp them. And if you put them on the bottom of their feet, their little toes will curl around your fingers. So that's to help them hang on to you. And then Babinski, rub the bottom of their foot up and around, and their little toes will flare out. And that's a good sign. This should disappear by about 24 months. They also do this. Anybody work on a neuro cord? We should not see this in adults. So if we see this in adults, that means they have neurovascular problems. So, but you will see this in the baby. And the gown I already told you about, rubbing the finger in their trunk will cock up, which is very cute. All the students love it. Okay. Some of the medications, you guys got to look it up. The eye prophylaxis. So all neonates get the erythromycin ophthalmic ointment, and this prevents transmission of gonorrheal and chlamydial infections from the birth canal. Vitamin K we talked about. The aquavitamin. They get a single injection of this, 0.5 to 1 milligram to prevent hemorrhage. And this is given in the vastus lateralis. Cord care, we used to do alcohol. Roanne used to put triple dye on the cord right after delivery, which turned it blue and got the tummy all purpley blue on the babies. But we don't do anything with those cords now, okay? And so you just tell mom to keep it clean and dry, no tub baths, until the cord falls off and heals, that area heals. Keep the diaper folded down and monitor it for any signs of infection. Bleeding, drainage, redness. So right after delivery, the cord is clamped and cut, right? And that cord clamp is removed typically about 24 hours when the cord has dried. So you want to determine that the cord is dry before you take it off. But it usually dries up pretty quick. That's why once they get out to the postpartum ward, we can't even see that they have 3 vessels in their cord. So you have to see that right at delivery to evaluate that. We also tell moms not to pick at that cord because it could cause hemorrhage. So we don't want that to happen. Circumcision care. They may use a bell or a Gomco type, depending on. It used to be the obstetrician did this, which made no sense to me, but now the pediatricians are the ones that do the circumcision. And it's just according to doctor's preference. But the bell, they put on a little cap and they leave a little plastic ring there. And then the Gomco, they put the gadget on and then they cut the foreskin and don't leave anything there. Okay? So then the little ring will fall off, and if it's the Gomco, then they just keep Vaseline gauze wrapped around it for the first couple hours. And then once it comes off, then we just tell the moms to put Vaseline around that area. You know, put the diaper on loosely and just watch for bleeding at that site. They do give the baby some lidocaine and topical creams to numb the area. But the circumcision is basically removing the foreskin of the glands. I'm sorry, what I call it. Plasticel is the one with the ring. And typically that ring will fall off in 8 days. And you don't use any Vaseline. The Gomco Bell, you use the Vaseline. So if you ever have, and they usually do circumcisions on the day that the baby and the mom are going home, just to make sure the baby is stable. But they do monitor that every 30 minutes for a couple hours. And if the baby has not voided by the time they leave, we make sure that we tell moms to let us know if the baby doesn't void, to let the pediatrician know. All right, breastfeeding. So we all know that breastfeeding is best. It enhances maturation of the GI tract. It's very good on the stomach. They receive the antibodies that moms have and immunity to a lot of things the moms have through the colostrum. Studies have found less likely to die from SIDS. Studies have also found it may help prevent lymphoma and diabetes type 1 and enhances cognitive development. The American Academy of Pediatrics say breastfeeding exclusively for the first 6 months up to 12 months is good. Or if you're formula feeding, they need to have iron fortified formula. Also, some other pros is it helps with otitis media because they don't get the ear infections, RSV, pneumonia, UTIs, bacterial meningitis. Did anybody hear that report out recently that broke my heart? It's like, oh, I shouldn't say that. That they've not found that breastfeeding helps you later in life to combat a lot of problems. So I'm like, how do you do that? But it definitely helps in the infancy stage. Helps a lot. But like, why they came out with that? But. Okay. And there's advantages for the mother also to breastfeed. They found that it decreases the risk of ovarian, uterine, and breast cancer. Definitely promotes uterine involution, which is what?
Moving back, we're supposed to.
Yep, uterus getting back to where it belongs, and that's why our moms complain about cramps when they're breastfeeding, because that's what's going on. Helps them lose weight, because they're burning off that extra fat that they've put on. Weight. They've also found it helps prevent osteoporosis. Bonding, very convenient, saves money, fewer supplies. So there's a lot of good things about breastfeeding. But with that being said, we never want to make our moms feel bad about not breastfeeding. Formula-fed babies do just fine. I ended up having to formula feed both my kids. They were tongue-tied and turned out later on. Didn't know that at the time, but it just didn't work. But it's a big commitment for moms. I mean, it's totally all mom's job. And some moms just aren't comfortable with the whole breastfeeding thing. So, you know, we never want to make our moms feel bad. And they're really pushing the breastfeeding exclusively in the hospital. So they're not giving out pacifiers just because they don't want to encourage that. What happens with pacifiers, they really discourage them for the first 2 weeks because it can cause some nipple confusion. Definitely a pacifier is different than the breast nipple, so it can cause problems with breastfeeding. So the hospitals that are baby friendly, they call them, don't provide any pacifiers. If moms want pacifiers, they have to bring them or buy them on their own. So the nutrients they need: energy, carbohydrates, fat, protein, fluids, vitamins, minerals. The big thing with moms, again, formula is fine again. They don't need any water. So even if it's summer and we all think, oh, you know, baby needs a little additional water, we don't want moms to add water into their diet. They get enough with the formula and the breast milk. What happens if you give a baby water, they'll fill up on the water and then they won't get enough calories in. So no water for the first year. Sometimes you have to add, well, like cow's milk is not the same as formula. They would have to add a lot of vitamins and calories to cow's milk. Breastfeeding moms, sometimes they have to give extra vitamins also. I think my daughter's giving our new grandbaby D. Yeah, D. Big thing with formula, I'm not sure if I can use this one, but we want to make sure our moms know to mix it correctly. Because if it's powder, which is really the best formula to store because it keeps much longer than ready-made and is less expensive also, but that they dilute it according to the instructions, because if they dilute it too much, it's not going to have the same nutritional content, or too little. So that's really important. Okay, so with lactation, prolactin is released, which stimulates milk secreting cells. So prolactin is released from the anterior pituitary. And this is in response to suckling of the baby. And breast milk is on a supply and demand basis. So the more you nurse that baby, the more you're going to have bigger supplies. So that's why we really encourage our moms for the first few days to really try to feed that baby often. We used to say every 2 to 3 hours, and every time I go back to postpartum every year, the lactation consultant has new ideas. So the idea is now just to make sure that they get 8 to 12 feedings in 24 hours. Because they do what's called a cluster feed, where they may eat several times in a row and then sleep for a stretch. So as long as they can get that baby to nurse 8 to 12 times in 24 hours, we're not waking up to sleep the baby trying to get them to nurse as much. So they want the moms to definitely nurse that first breast until baby is done, birth that baby, and then try the other breast. Okay? So we want them to totally empty that first breast. Again, things change. It used to be nurse that baby 15 minutes and then change sides. But now they're saying just let that baby nurse as long as they will nurse on the one breast. Hopefully to empty that breast and then birth them, and then try the other breast. And then the next time you're going to start on the opposite breast because they didn't nurse as long on that breast. And that'll help with the supply. Also, oxytocin's released, and that helps with the letdown. And this letdown can occur once their milk is in, even if they just think about the baby, which can be kind of frustrating for the moms. Or if they hear any baby cry, sometimes it will happen. Just to warn our moms, that can occur, and breast pads need to wear the breast pads to help with that. And this also stimulates the nipple erection reflex. A little more about the human milk is, again, we start with the colostrum, which is a clear, yellow, extremely rich in immunoglobulins, high in protein and minerals, but less fat. Gradually changes to the mature milk. Pure yellow, extremely rich in immunoglobulins, high in protein and minerals, but less fat. And usually it's the second or third day when the milk comes in. So mature milk changes, the fat increases. And we want to make sure, and the most mature milk occurs about 2 weeks, we want to make sure our moms do empty the breast, because it's like in the initial feeding, the initial part of the feeding, it's skim milk, then it changes to full milk, and then the hind milk is the cream, and they need all those parts, okay? So, and it takes 10 to 20 minutes for this to occur. So we want to make sure that the mom really does let that baby nurse hopefully at least 20 minutes on that first breast. At 2 weeks, the mom should produce about 720 to 900 milliliters of milk in a 24-hour period. Babies have different growth spurts, and during those growth spurts, they'll eat more. And it's good for the moms to know that. It's like, oh my gosh, I'm not producing enough. This baby's never full. But they do eat more during the growth spurts, which are at 10 days, 3 weeks, 6 weeks, 3 months, and 4 to 6 months. Positioning. We want our moms to definitely change positions. We don't want them to nurse that baby in the same position every time, because it will empty all of the milk ducts. So we encourage them to change positions. Football hold is just, bringing the baby in, legs tucked back here, and bringing the head in. And that is great for our C-section moms, because that baby's not sitting on that incision. Then there's the old-fashioned cradle hold. Lap, and sideline is great for when you're sleeping at night. Get your significant other to bring the baby to you, and you can feed the baby in bed and say, okay, I'm today. You get to change the baby, bring the baby to me, put the baby back. Because they want to be involved, right? So that gives mom a little break. And it's important that definitely that moms are latching the babies on correctly, because that can cause damage to the nipple, which can cause infection to the breast, so we don't want that to happen. So we encourage them to support their nipple in a C hold back here. Okay. Stimulate the baby to open their mouth wide. Make sure that their tongue is down. And then you're going to pull the baby to the breast, not the breast to the baby. You know that they are getting it, they have a good hold. When you hear swallows, it should not be painful, and mom should be able to feel the letdown. And you want to make sure that most of the areola, or as much as can be, put into the baby's mouth as possible to drain all the ducts. They really have to have a lot of that areola. If mom, for some reason, needs to stop the baby nursing, make sure she's just pulling the baby out, that she stops the baby from sucking, so they need to put their finger in the corner of their mouth. First, wash their hands before, but stop the baby sucking and then remove it from the breast. And that will hopefully prevent them from having nipple pain or damage. Okay? Alternate breasts, as I said. Some moms will use a little safety pin in the beginning because, you know, after their milk comes in, they can usually tell, oh, this one's fuller. This is the one I need to start on. But initially, it helps to get a little safety pin and put on your bra so you know which breast you need to start with next. So you want to alternate breasts. We want them to. And again, first breast until it's empty. And then attempt burping, although a lot of times they don't burp as much either because they're not swallowing as much air. And then attempt to nurse them on the other breast. Formula feeding, 3 types. There's cow's milk, soy-based, and therapeutic. And like I said, formula is good. You know, they have really perfected as close as they can to mother's milk. They add more vitamins, especially D, iron, different things. Soy is used for lactose intolerance, as well as vegan parents. Okay. And sometimes this will be picked up at the hospital and sometimes not, where they're not tolerating the cow's milk formula, cow's milk-based formula, and they'll switch them to soy. If the mom says, yeah, my first child, you know, couldn't take the regular formula, we had to go to soy formulas. Sometimes the second child will be the same. Therapeutic formulas are used if there's an allergy or intolerance to the cow's milk also, so like Nutramigen is one. And they're more expensive, of course. I already talked about the proper mixing. Adding cereal, they really need to talk to their pediatricians about that. What I have is you should never add it until 6 months of age or later. And since I've had grandchildren recently, I'm kind of in touch with it. They're not really doing cereal anymore. They're just starting with fruit and vegetables. There's a vegetables in there. Might be vegetables in there. But because of all the allergies, you know, the gluten problems and all that, they're not doing cereal, to my knowledge. I don't know about that. Who's had a baby recently?
There's been some recommendations for it because it's really bad for their intestines because it's not clean enough.
Okay, I never get it. Okay, you're right. I didn't mention it. Yeah, I'm not sure how long they use for it. Okay. Yeah, and that's what they're saying. Don't do it before 6 months, definitely, because their intestines can't handle it. All right. When juices start, and again, this is pediatrician based, it should be given in a cup, not a bottle. And never, never, never prop bottles. We need to tell moms that if we catch them doing it in the hospital, right?
Why shouldn't it get in a bottle?
Probably because of the sweetness. I don't have that down on here, but
Those
you know,
bottles come with
probably, yeah. And you don't want them to go to bed with a bottle for the same reason, you know, it decays the teeth. What would you say, Chris?
Teeth related. They
Yeah.
don't want them to
That
have
sugary-
all in their mouth all night long.
Yeah.
Well, by the time they have juice, they should be.
Yeah, by the time they have juice, which I don't have, and that's why it changed too, you know, might be, that's probably at least a year, because we don't want to give juice and replace the formula, so, yeah. Getting them off the bottle early, sometimes it's harder on the moms, sometimes to get them off the bottle than it is the child. Okay. Also, never use honey in a child less than 2, because that can cause botulism. We think honey is awesome, and it is good for us as adults. All right, some concerns we want to be on top of is if, and we tell all our, yes, botulism. Yeah. So, you know, we want our babies to sleep, and they will be fussy, but if they're sleeping more than usual, and moms know their babies, they know when something's wrong, or if they're just extremely fussy, they need to call a pediatrician. Slow weight gain, they'll be on top of that. Jaundice, again, be watching your baby for that yellow color. And again, they're more on top of that. Used to be they didn't see babies until like 2 weeks after birth. And now they're seeing them like in a few days. And then again in 2 weeks. So they're really on top of that. Storage of breast milk can be refrigerated up to 3 days because it's got wonderful bacterial static qualities. And this might vary a little bit, but from what they tell you, it can be frozen for 3 to 4 months, and I remember hearing like a year. So, deep freezer, that's what it is. That's right. Never microwave, right? Formula or breast milk, because you get those hot spots. You want to have them thawed in warm water. Breast care, we talked about the cabbage leaves, so you just peel off a leaf of cabbage, put it in the freezer, and they just fit real nicely into your bra for engorgement. We pretty much hit on mastitis already. You know, you want to use the warm, not the cold limitedly. They can get yeast infection in the breast also, because especially if the baby gets thrush, which is a yeast infection in the baby's mouth. So it's good to check your baby's mouth and see that what they'll see is a white film in the baby's mouth. Then that needs to be treated because that's going to be passed on to your breast, and then you're going to get a yeast infection in your breast. So medications, most all medications pass through the breast milk, but usually in very small amounts. The best way to do it is to take meds after you've fed the baby. It's good to use single symptom drugs instead of multi-symptom drugs. And always check with your physician. And always watch the babies for any kind of a reaction. Okay, so then we're going to start with our high-risk newborn next time. Just cover this little chart and then we'll get into it. So, temperature. We want to minimize cold stress, definitely. Maintain their temperature. Now that's a little low, 96.8 to 97.7. Usually we want them about 97.7 to 98.6. So we're continuously monitoring their temperature. We don't want to rapidly warm them up or cool them down. Use a cap. It depends if our high-risk babies are in an isolette, on a radiant warmer. If they're on a radiant warmer, they're just in a diaper, and they have a little electrode that's taped to their tummy to monitor their temperature, and they have to have their t-shirts off for that. Isolates are a certain temperature, and they wrap them up a little bit in isolate stuff. But if you have a baby having a problem, typically we put them on the radiant warmer, and you'll see them with that clothes on. We can monitor their breathing, we can watch their chest for any retractions and that kind of thing. So they will not have anything on but a diaper. They won't have a hat either, because they can mess up we can make them too warm. Definitely we'll talk about the babies that we're especially monitoring for hypoglycemia, assess their tolerance to oral. We'll talk about their set being immature, what different ways we can feed those babies. And bowel sounds, change in stool patterns, monitor weight gains, semi-prone for increased oxygen consumption. I worked in a high-risk nursery for a few years, and we used to say we have to balloon them to breathe. Sometimes they're on monitors. If they stop breathing and their heart rate drops down, we kind of go hand in hand. So we would go over and tap on the isolate to breathe. But we're going to monitor their O2 therapy and assess for any signs of respiratory distress, which are running or nasopharynx or cyanosis and apnea. And what apnea are we concerned about?
Greater than 15 seconds.
Perfect. All right. Any questions? Moving right along. All right.